Hi, Dr. Centeno. Sorry, running a few minutes late today. Had a meeting that finished late. So today, I'm going to talk about an interesting topic. There's been a lot of questions about COVID-19. We're obviously entering into an uptick in all sorts of respiratory issues, which we do every winter. And this one, perhaps a little bit of a bigger deal, just because I think we've had a lot of patients and really a lot of the population who has been sheltering, and that has during the pandemic, and that has likely decreased their immunity, meaning we all get exposed to small amounts of things all day, every day, and those exposures are necessary for our immune systems to stay active and healthy. So when we don't do that, we tend to have immune systems that are much, much weaker. And I think that's kind of what we're seeing right now with the quote triple-demic that's being talked about. But since I do get a lot of questions about COVID-19, I wanted to update everybody as to where that data lives right now. I see a lot of irrational fear out there around COVID, especially in the patient population that I treat. So I wanted to look at what the data really was. So I'm going to take a second here and just get this started. So we'll be talking about that today. Start with a small lecture, and then we'll go to questions either about that or anything else. Okay, so COVID-19 in 2022. Again, lots of patients asking about this, and I think I'm seeing a lot of irrational fear out there that isn't actually based in any of the existing information. So it's time to start looking at what's real in 2022 and what's just good caution and what's irrational. So let's take a look at all of that. So COVID-19 in 2022, the physician scientist perspective. So these are my publications listed in PubMed as of this morning under one spelling of my name, Centeno CJ. There are more probably listed under Centeno C. But suffice it to say that I've published a lot of peer-reviewed research, and each one of these papers takes dozens of hours to create and go through the peer-reviewed process. So at this point, I think I can qualify myself as a physician scientist. In this particular field of orthobiologics, for example, there's not a single physician at the local university that has this many publications on the clinical use of orthobiologics. And in fact, I don't know if there's another physician in the United States at any university who does. So I think I qualify at this point. So my job as a doctor is to teach you about risk. Now, that's on both sides of the equation, right? Sometimes I'll see patients that are accepting far too much risk and they don't understand how much they're accepting. So it's my job to educate them on that. And on the other end of that spectrum, I also see patients who are have an irrational fear of something that really isn't based in any known scientific information. And it's my job to talk to them about that as well. So as you know, you were there, I was there, the US and the world lived through a pandemic, and that started in kind of late 2019, hit most of us in the first quarter of 2020. And when we were really in the brunt of that pandemic, there was more quick and dirty, what I would call pseudoscience than hardcore science, meaning we were all in an information poor environment And so lots of mistakes were made. And we're only starting now to unravel the magnitude of some of those public health mistakes. One of which was this whole insanity, right? The bandana mask. And there were many, many others. We're now starting to see what the health effects and the mental health effects were of lockdowns, and they're not zero, they're quite significant. So we're now finally getting to that place where some of this stuff is starting to be analyzed. So what does that more recent data show us about the mistakes that we made, the things we did right, et cetera, et cetera? So today we're going to answer a couple key questions that I think are in patients' minds. You know, what's the current risk of COVID? How does age and other illness impact your COVID risk? What about long COVID? And then for a lot of my foreign patients, you know, they're coming from environments that are very different when it comes to looking at COVID risk. And so how is this being dealt with in general in the United States? So here's a big one, right? What's the current risk of death per infection? And how does age or comorbidities impact that risk? Because that's a really important thing to understand. If you don't have much risk of serious illness, then you shouldn't really be concerned about something. If you have a high risk of serious illness, then you should be. And obviously, if you don't have much risk and you're still concerned, that's an irrational fear that's really getting in the way of being really living your life, but also can get in the way of medical decisions as well. So this is right off the CDC website here. And it's important to look at because you're not going to see this data anyplace else, meaning the data is reported differently in a raw format on the CDC website. So I had to personally adjust this for US population in these different groups. So it's a little bit bizarre to me that you won't see this, although you maybe heard about some of these things. So let's see, I am in this age group here, 50 to 64. And my risk compared to the people above me is minuscule. So I'm going to now outline all the people above me in age here. So as you can see, that my risk compared to that risk is tiny, and it's about 23 times or 2,300% less than anyone who's older than age 64. And if you notice, the vast majority of COVID deaths are still in this 85 and older population. And guess what? If you're 85 and older, you're likely to drop dead at any moment, i.e., people die. And people die of all sorts of things once they get to be 85, 86, 87, 88, 89, 90, etc. So the first thing you need to understand is, and I see this all the time, I'll see a patient walk in who is 35 years old and has an extremely tiny risk of COVID death or serious illness based on that age, but they don't really understand. They're still irrationally afraid. Same thing with patients that are 45 years old. Again, tiny, tiny little risk based on age. So COVID is still an old person's disease when it comes to serious illness or death. And this is, again, right off the CDC website. This is all this week's data, or updated through this week, or I guess last week. So these are the comorbidities that people died with COVID. And you get a sense of what these look like here. But these are all pretty big problems, right? Diabetes, sepsis would be a blood infection, emphysema, heart arrhythmias, stroke, cancer, heart failure, heart attack, high blood pressure, etc. Now, you're at the highest COVID risk level if you have 3 or more of these. So if you've got hypertension, and let's say you're a diabetic, and let's say you have heart failure as well. you would be at a higher risk if you've got 3 or more of these. Now, please notice what's not on this list is a lot of the things that my patients have. My patients have things like MCAS. My patients have things like HEDS. Not on this list of what the CDC would consider an important comorbidity for an increased risk of death or serious illness due to COVID. So now let's look at the infection fatality rate. That's the number of people who die versus the number who were infected. Now, one of the problems with all of this is that throughout the pandemic, it's been a moving target, right? The problem is that the number that test positive for COVID is some tiny fraction of the number who actually had COVID and either didn't get tested or it was so mild that he didn't even know they had it, which we know now is a big thing. But the best paper I can find right now that's the most recent, because all of this changes as we go through different parts of the pandemic, and I'll show you that graph here in a second, is that for someone who's 0 to 59 years, so I'm in that age range, we're talking about a 1 in 3,000 risk of death. Not high. So at this point, probably lower than a risk of death due to something like a car crash, depending on where you live. Some states are safer as far as risk of death, annual risk of death for car crash versus not. And there's a nice back and forth discussion on this that tries to give both sides of this argument some time to talk about it, the new data being published versus the old guard on this topic. So if you want to read about that, that's something you can go read about. And the main problem with calculating IFR is also that existing death rates are died with a positive COVID test and not died from COVID-19. Hence, those numbers are exaggerated, right? We have lots of people who tested positive for COVID, who went in the hospital and died of something else, and that's counted currently as a COVID death. So makes calculating this IFR very, very difficult and problematic. Now, this kind of shows you here the trend and what's been happening. So if you look at total COVID-19 hospitalizations, which is going to be this line, and then hospitalizations primarily for COVID-19, what we're seeing is that as we go through the original pandemic over in here, that we had high hospitalization rates. Then we go through Delta, it goes up a little bit. And then with Omicron, it begins to go down. And in the late Omicron, where we are, at least as of June, when this data was collected here, it was way, way down again. And I'm going to show you some other data that fits with this that's updated as of last week. So from that report, during the later Omicron period, the majority of in-hospital deaths occurred among, again, adults who were over 65 years of age and adults with 3 or more underlying medical conditions. Those medical conditions I just showed you, which were all pretty serious things to have all by themselves. Now, this is a really interesting one here because this is data as of December 8th, 2022. So very, very recent. And what we see here is the number of COVID-19 deaths, which is going to be the blue. So this is all going to be COVID-19 deaths here. And then we've got the number of deaths due to influenza. So what we see here is the number of deaths due to respiratory illnesses going up and the number of deaths due to COVID going down. That's coming right off the CDC website. So at the end of the day, this is sort of what's driving this triple-demic concept. And the problem is that flu deaths usually go up in the winter. You may not think of flu as causing death, but it causes about, give or take, 50,000 US deaths a year. So yes, people do die of the flu. They tend to be either extremely young without an formed immune system or extremely old and pretty sick. So what about long COVID? Let's look at long COVID here. And so there's a medical version of long COVID, which is continued respiratory and other symptoms in people who had very severe disease. So these are people who ended up in the hospital or an inpatient or outpatient intensive care, meaning that these are folks who ended up going home from a short hospital stay on oxygen, for example, and had to have a respiratory therapist visit the house. These patients were very, very sick. And so it certainly makes sense that some of them would have injured their lungs and or other things. They may have fatigue related to that lung injury. They may not be able to function. They may still have shortness of breath. They're still getting respiratory therapy 6 months later, et cetera, et cetera. But there's also a second version of long COVID where the diagnosis is less clear. Someone who had kind of mild to moderate flu-like illness and tested positive for COVID, who reports mainly these types of symptoms. So they don't necessarily have respiratory issues, but they've got these other things that they're blaming on COVID. And in fact, if you look at some of the information coming out of the media, it's been estimated based on one estimation type study that 23 million in the United States alone might have this form of long COVID, and that was going to cost us trillions and trillions of dollars. So for that second version of long COVID, there were basic unanswered questions, however. The most basic was, how are COVID positive patients different than COVID negative patients when both showed up to a hospital ER, right? So this was at a VA hospital. They took 1,000 patients randomly who showed up to the ER, all with a respiratory problem. They did some testing. A significant portion of them were COVID positive. Another significant portion were COVID negative. Then they followed these patients for 3 months. Now, in this case, what they did is they gave patient-reported outcome measures. That's what this means, PROMs. And that looked at things like pain and disability and function to both groups at 3 months after that ER visit. So if long COVID after mild illness is common, then the COVID positive group would have much more reported disability at 3 months after that ER visit than the COVID negative group. And this is the paper out of JAMA that I'm quoting. Problem is, it was the opposite. So here we have patient-reported outcome scores where the higher scores are better here. And these were the patients who didn't have COVID, and those were the COVID patients. So the COVID patients were actually doing better on cognitive function. When it came to physical function, again, COVID here, non-COVID there. So again, the COVID patients were doing better on physical function. Social participation, which is sometimes an indicator for depression, the COVID patients doing better than the non-COVID patients. Now we're scores lower is better. So if you look at anxiety, the non-COVID patients were more anxious than the COVID patients. If we look at depression, the non-COVID patients were more depressed than the COVID patients. We look at fatigue. The non-COVID patients were more fatigued than the patients who tested positive for COVID. Sleep disturbance may be kind of equal there. And pain, the non-COVID patients had far more pain than did patients who had had COVID or COVID positive. So as you can see, this study doesn't support this idea that long COVID is something that's that's happening. But instead, it actually supports sort of a different conclusion that really the presence and persistence of all of this stuff may reflect more of a pandemic exposure, what the pandemic and isolation and lockdowns and money troubles and the money whiplash that we all saw during this may be causing this more so than the SARS-CoV-2 virus. So living with COVID. The US version, the needs of the many outweigh the needs of the few. I think we're all in that place in the US, and that is masking is optional and a personal choice. And lockdowns only happen if the hospital system is about to be overloaded, meaning we will only lock down if there's concerns about the hospital system. Now, the US has one of the highest number of ICU and hospital beds per capita in the world, which is a function of our for-profit hospital system. But in this case, it helps us quite a bit because it's much harder for US hospitals to become overloaded than it is for hospitals, for instance, in other countries. And the local health departments determine the rules of what goes on in that jurisdiction. So our clinic, we observe masking policy handed down by our local health department. Right now, that's no masks, but listen, tomorrow it could change, and we would be happy to mask up if that's what they recommend. We installed a UV filter in our air handler during the pandemic. That remains. You must be vaccinated to work in our clinic. There's no give or take on that. And in fact, a federal judge today just handed out a mandate that it wasn't okay for employees that worked in healthcare settings to have choice when it came to being vaccinated. And we can certainly mask during procedures at your request. We did that last week. We had a patient who was concerned about COVID. That person was wearing an N95 mask when they came in and asked if we would all mask during the procedure because she would have her mask off. And we said, sure, no problem. Happy to do that. So in summary, please don't have an irrational fear of COVID or long COVID in 2022. We certainly respect your personal decision on how to mitigate COVID, and we will obey any federal, state, or local mandate for virus mitigation. So if they tell us to do X tomorrow and that's required, we will absolutely do it. So anyway, let me go to questions. That was kind of a long one. I don't usually go that long, but there was a lot to cover here, and I wanted to make sure we covered it all. So let's go to questions now here. Duck P. Can deep neck flexor atrophy cause the head to feel heavy? So Duck P, that's an interesting one. There's been some studies on deep neck flexors. So let's talk about what that is. So this up here, deep in here, longus coli capitis, are the deep neck flexors. Now, weakness in these in various studies has been associated with headaches. And while that research on head feeling heavy hasn't been done, my overall sense is that there probably is a connection there between atrophy there and the head feeling heavy. Duck P, can sensory motor impairment in the cervical spine, muscle atrophy, dysfunctional proprioception cause some unsteadiness with walking? Sure, we see that pretty frequently. Centeno, a PICL procedure about 12 days ago. I may need to have a brain MRI with contrast a few weeks. Wanted to know if that will affect healing of the PICL procedure. That's a good question. I don't know that we know the impact of something like gadolinium on bone marrow concentrate or mesenchymal stem cells. So I don't know the answer to that one. Let's see here. Let's take a quick look. So one of the ways that you guys can search some of this stuff, I'm going to teach you how to do that, because obviously there's so many different medications and other things that people can be exposed to. So let me go ahead and share my screen there. Okay, so if we type in Entrez PubMed. That's going to bring us to U.S. National Library of Medicine, PubMed. And we can look up mesenchymal stem cells. I'm an awful speller, so I may have misspelled that, and I guess I got it right. Let's see. So can we see if there's any So all I'm looking for is a study that really looked at the effects of gadolinium on mesenchymal stem cell health. And there's a bunch of really deep sciencey type experiments going on here. You know, the last time I looked at this, Bethany, I didn't see an issue. That's probably going back to around 2014 or 2015. So I'm going to say that based on what I recall, the last time I did this search and looking at this, I would say probably not a problem. How many PRP treatments does it take to stabilize severe SI joint laxity? So generally what I tell patients there is I start with prolotherapy because that can help do the same. So when it comes to prolotherapy for women, that's usually takes the most because women are more likely, obviously, to have injured the SI joints in childbirth. We're talking about 6 or 8 prolotherapy treatments. And generally, you can half that for PRP. So PRP is therefore going to be 3 to 4. And you can half it again if we're talking bone marrow concentrate. So let's say 1 to 2. So that's generally how all that goes. Let me see if I can unshare my screen here. There we go. Regenix, submitted by Andres. How do you view the COVID vaccine? Many have been injured from it. I believe it caused me to be flocked, similar to Cipro. Yeah, I don't think we have any evidence that that happened. So again, just realize that we wouldn't accept as making someone a candidate for our procedure or not, either COVID-19 being the cause or the COVID vaccine being a cause, because we've got no way to draw those two things even scientifically. We've got no problem with the COVID vaccine at all. I ended up getting vaccinated. You have to be vaccinated to work in my clinic. There are no exceptions to that rule. In fact, we fired one person based on their refusal to get vaccinated. Now a federal judge just upheld that, which is good to see. But the bottom line is, how do I currently view vaccinations? Well, I think only if you're in an at-risk scenario. So if you are, let's say, older, 70 years old, for me, I'd be vaxxed up. I'm not 70 years old. Or if instead of being at my normal weight, I was 350 pounds, I'd be vaxxed up, especially if I had diabetes and hypertension. So it all depends what your risks are as to whether or not you want to do something like that. And I think that's kind of a good way to look at it going forward. Now that we know that COVID death and COVID severity has gone way, way down, going forward, this is going to be a very personal choice. Now, if you're working in a healthcare setting, you probably don't have a choice, meaning that the average large hospital system is probably now not going to allow you to work in a patient-facing role without being vaccinated. Lissy, is it possible for a doctor to inject a vertebral artery in the neck? Because some doctor was doing a procedure in the upper neck, with no ultrasound guidance or x-ray and end up with that got cut off there. But yes, it's more than possible to inject the vertebral artery in the neck. And if you were to inject something like bone marrow concentrate, PRP, or prolotherapy solution into the vertebral artery, that would be a bad day for everybody. You would really mess that person up, possibly on a permanent basis. So that's one of the reasons why we always talk about you can't just go to someone who knows how to inject, let's say C0, C1, but that person needs to have a lot of experience doing that because of the vertebral artery. And they also have to have digital subtraction angiography on their C-arm in order to be able to do that so they can see whether or not they're in that artery. Stephen, I'm not vaccinated. Some doctor in Germany advised me not to. I don't think there's any connection between stem cells and the vaccination at this point. Now, just realize, I don't know what our current U.S. entry guidelines are, but the last time I looked this up for a patient, we were still requiring vaccination or something like that. So let's say I'm looking at it right now. If you are a non-U.S. citizen who is a non-immigrant, not a U.S. citizen, U.S. national, lawful permanent resident, you'll need to show proof of being fully vaccinated against COVID-19 for your travel air United States from a foreign country. So, yeah, you need to be vaccinated to get in the U.S. I'm not sure what I can tell you there. Fatchin, is there issue having an MRV? I think it's with contrast 3 days after a posterior PRP injection. Probably not, but I don't know why you would want an MRV. So if you're going to get a posterior PRP injection, you're going to want to see if treating the instability can help any vascular issues you have. If you're doing an MRV to look at something like internal jugular vein stenosis, it's not going to be nearly as good as doing something like a CTV, a CT scan with a venogram. And I don't think I'd do either one of those until I knew what was happening with the results of stabilizing the cervical spine. Regenix, submitted advanced by Harry Winston. We have a great deal of rising cases here in the UK, but most people I know seem to be getting sick, as when a mess first started. Maybe the vaccines are helping. Could be, or I think COVID in and of itself has gotten less virulent. Listen, if just look at the 1918 pandemic. I'm not sure if any of you are a student of history. I'm a big history buff. But the 1918 pandemic was the opposite, right? It impacted the young, and the young were dying, and older people had immunity against other stuff that gave them cross immunity against that particular form of influenza. Now, the 1918 pandemic that was so nasty and killed so many people ultimately evolved into what we call H1N1 influenza. Why did it become less virulent over time? Well, a number of reasons. One was people had immunity to it. Another was that the goal of a virus is to replicate. And you replicate by infecting as many hosts as possible. And if you kill your host, you don't get to replicate as much. So all viruses tend to evolve into being less virulent because that maximizes their spread. So just look at the history of the 1918 pandemic, and you'll realize that it ultimately evolved into what we currently call, one of the main flu viruses of today, which only kills you if you are really, really, really sick. It's not killing unhealthy people and hasn't for a very, very long time, since about 1920. Fatcha, my main issue with the neck is bending it left or right laterally. Makes me feel dizzy at the top of my head. What can play the biggest role with it? Muscle spasms, atrophy, or some ligament? Again, left and right laterally is going to be C1, C2 overhang. So that would be more alar ligament. But again, we need to look at all that. And that would be during a medical consult where we can go over that, and I can try to explain that as best I can. But if you have a lot of C1, C2 overhang, that would be the cause. Lissy, there's a doctor in Florida who's charging their patients prolotherapy for thousands of dollars. Then where you go get a local doctor to do it for $300 or $350. I don't know which doctor in Florida you're talking about, but listen, if you're going to get prolotherapy done, this isn't like buying a TV. And that's probably the biggest advice I could give people, because listen, I can go to Best Buy right now, right? And there's lots of different TVs. And yes, some of them are a little fancier than others, like an OLED screen, etc. But at the end of the day, they're all pretty good. And if I buy a 55-inch TV from X, Y, Z, or A, B, and C, they're all going to be within a range of pretty good. Maybe one might break sooner, the other one might last longer. But at the end of the day, we're not going to see huge variances in the quality of those TVs. Now, medical care, and especially in this area, is hugely different from one provider to the next. So you can get a provider that does blind prolo for, I don't know how much they charge, but let's say you're right. Let's say $350 in your neck. Now that's pretty damn dangerous, because if they inject that prolotherapy solution into your artery, then you're probably dead. So obviously that may not be your best bet. Then you can get doctors who will do it with a little bit of guidance, like some of the clinics, and there is one in Florida that does it, I would say, with that tries to use guidance but isn't really using guidance. And then you can go all the way up to how we would do something like that, where we're injecting the ligaments under either ultrasound or fluoroscopic guidance, in the joints in fluoroscopic guidance with contrast and digital subtraction angiography. Those are three hugely different procedures. Like the difference between your 1970s color TV when it first came out, the early plasma models, which today you'd probably throw away, and the state-of-the-art 97-inch OLED. They're almost not even all TVs, right? They all kind of do the same thing, but if you've ever looked at that 1970s video feed on YouTube, it's awful. You can barely see anything. So that's the differences and the type of differences we're talking about here. So I wouldn't be silly enough to shop based on price for something like your neck, where if they inject the wrong area, you're dead. That would be a bad day for everyone, right? Ah, shit, I shouldn't have gone the discount route. Too late. Faction. There are thousands of young patients in the U.S. who attribute their declining ability to get back normal health and life to their prior non-severe COVID. What does the latest research say about long COVID points at? Doesn't exist. That's what the most recent research says. The highest level research we have on that topic is that JAMA study I just shared. So yes, they seem to be really relating what the effects of the pandemic have done to them, i.e. shutdowns and all the uncertainty around the whole COVID-19 pandemic, but not the SARS-CoV-2 virus. So that's the best data we have right now. Now, who knows? Maybe that changes next month and there's even a better study that's produced, but that's the study that we have right now. So I would say right now, the data is that's more mass hysteria than it is related to a virus. Connor, on Mepedia, there's a post around MMP upregulation through mold infections, hormones, and other cofactors that degrade collagen. What's your take on this? Yeah, I've got a whole video, Connor, I did on that, and I looked at that in quite some detail. We don't have any evidence at all that any of those things degrades collagen and causes ligament laxity. That's the reality of it. We have a single paper out of Germany that seemed to relate it to CCI, but that single paper had some very serious problems, i.e. we didn't know the prevalence of the positive tests, and that one was on Lyme disease, of Lyme in that journal population in Germany. So what they really just may have been describing is a whole bunch of patients with CCI who happen to have some positive Lyme tests, but the guy down the street also has a positive Lyme test. That's it. That's all that's out there. I just reviewed this. So if you look back on YouTube and you type in, I think it would be with the Lyme one. If you just type in Lyme, it'll come up. And you can go through that. But the data as I reviewed it did not support the statement that we know that mold infections and other things can cause CCI or even ligament damage. Do I have MCAS symptoms? If so, maybe that wasn't for me. As a question. Been advanced by Leslie. Is there any greater risk for people who have been mostly bedbound due to CCI? I don't think there's a bigger risk, but you need to understand that there'd be two different things to think about there. The first would be the depth of that hole, and I've talked about that many, many times. If you are not functional, then your hole is deeper, and the more time you've been not functional, the deeper that hole. So at some point, you've got to climb out of that hole back to recovery. So it means a deeper hole to climb out of. So i.e., less likely to go back to completely normal with just a procedure like this. And then on the other side, that person likely has some pretty severe symptoms. So they're likely to be more in that fragile egg category and get very, very flared up as a result of any procedure that's done, including this one. So those are the two things I think I'd think about if you were in that scenario or situation. If you're a patient that have POTS or tachycardia, are they at a higher risk because of the heart problems, dysfunction, biggest not of the body to rest and digest? Not that I've seen so far. Certainly, you would want to try to reduce that vagus nerve irritation and allow the vagus nerve to function more normally. But I haven't seen that to date in that, at this juncture, probably almost half of our patients have POTS/tachycardia. So if that were the case, I think we'd be seeing huge, huge differences in certain subgroups, and we're not. Regenics, advanced by Andres. How do you view the COVID vaccine? Yeah, I think I answered that one. Would it be beneficial for me to come back a couple months, do another round of facet injections, posterior ligament injections, PRP this time for my 4-month recovery from PICL? Do you feel like extra boost? You know, Bethany, we haven't had great success with this concept. Now, it doesn't mean that it may not work in some patients, but I've seen a number of patients get in trouble doing this. I don't know why that is, meaning they were doing great from their PICL recovery, moving right along, and then they'll get a booster shot and they'll fall off the cliff. I don't know why that is. And it may just be my own bias in looking at the 5 or 6 patients that have asked to do that. And maybe there's many more that are doing it and doing well. But overall, that's been my experience so far with that concept. So I would recommend against it right now. Regenics, been advanced by Sherry Kopp. My cousin had COVID 3 times. I would have thought he would have built some kind of immunity. Does that not happen with COVID? You know, Sherry, may just be a compromised immune system in that person. Maybe, you know, the other thing I think we need to be careful of is that our COVID detection for PCR has traditionally been run too many cycles. So there may have been some times where he really wasn't COVID positive, but did have a couple strands of COVID DNA in the nose or the nasal passages. So what do I mean by that? PCR is a technology that relies on amplification cycles, and each cycle doubles. And so it's logarithmic math. Now, so the difference between 2 cycles, so let's just do some quick math here, right? One cycle will be 2 strands of DNA go to 4. Another cycle, so that's 1 cycle. Now we're at 4 times 4. And now we're at, you know, so it just goes on, and these numbers get very, very big, very, very quickly. And so the difference, for instance, between 20 cycles and 30 cycles is the difference between all the marbles that can fit in Lake Erie versus all the marbles that can fit in the earth. So if we're running those tests at 35 to 37 cycles, which is common, then we may be getting false positives for COVID. So that's one possibility as well. Fatchen, what does it relate to when heart rate goes up to 100 beats per minute just because of staying upright for a long time? Yeah, so Fatchen, the biggest thing that we see there would be vagus nerve irritation. That would be the prevailing theory as to why that happens. Now, obviously, you have to make sure that you see a qualified cardiologist and get all the bad stuff ruled out, because there are bad things that can cause that particular problem. So you got to make sure that the experts on the cardiology side have given the, I don't know what's wrong, thumbs up to look at other causes. Fatchen, is the invasive cranial traction test the one that neurosurgeon does the best test to confirm its stability, since basically stimulating the same hardware is going to be inserted in your neck, holding your skull up for you? Well, yeah, I mean, so invasive cervical traction, let's all make sure we know what we're talking about. So that's where we take some screws and we drill them into your skull here and back here. And that's the invasive part. And then traction is to pull up. What does that test mean? I don't think anyone knows. I think I've talked about it here before. On the one hand, it could mean that you have some instability or vertical instability. And by pulling up, that's giving some distance there for the structures at the craniocervical junction. On the spinal or the medulla and brainstem side. It also could just mean that you have painful 0, 1, 1, 2, or 2, 3 facets, and you're taking weight off those facets. One of those, you might be reasonable to do surgery if everything non-surgical didn't help. The other one of just having painful facet joints is not a reason to do surgery. So that's my concern with that test, is it's going to sort of be a shotgun. Can a state of prolonged inflammation in the body from an infection in some individuals cause their already weak upper neck? No. We have no data to suggest that at this point. I think I know where you're going there, but we don't accept COVID-19 as a cause, or even mold or Lyme as a cause for CCI at this juncture. So if that's the only cause, then that's going to move us away from wanting to treat that person, simply because we don't know how that person got CCI. Obviously, how we diagnose CCI is that you have to have a reason to have it. You have to have the symptoms that match. You've got to have imaging that matches and response to treatment that matches. I don't know what that means, Ulysses. Can you assess for CCI without MRI contrast effectively? Well, we require a routine cervical MRI just to rule out the bad stuff, or the obvious stuff, if you will, in the neck. We also usually require a digital motion X-ray. As far as an MRI, I think, I'm not sure if you're asking if a contrast MRI or without contrast MRI is needed. We generally have difficult time diagnosing CCI off of MRI alone. We usually need movement-based studies, and the most likely one to show CCI would be a digital motion X-ray. Stacy, last week I got hit with a nasty case of vertigo for several days. Noticed that on my first 2 days of vertigo, that my usual tinnitus and facial pain were not bothering me. Not sure about that one, Stacy. Connor, my connective tissue disease on the severe side when I struggle to heal a basic cut, scrape. Does it impact the outcome? Certainly might impact how things go. It's possible. Now, many patients with an HEDS diagnosis have the same type of thing going on, and we don't see them having an overall different outcome than people who don't have HEDS. So I'm going to have to say probably not. But is it possible that it may have an impact? It's possible. Stacy, should I also said that if I clenched my neck muscles or clamped my hands around my neck, stabilizing vertigo was not as bad? Yes, Stacy, so that makes sense. It sounds like there was an aggravation of the upper cervical joints. All you're really doing is either taking weight off those joints or stabilizing the head on the neck. So you're reducing the bad information coming in from the upper cervical spine. That also may be helping, obviously, any instability that you have. Bobby, hello, Dr. Centeno. I have cervical instability due to a car wreck. I have bilateral trigeminal neuralgia and glossopharyngeal neuralgia. If I chose to do cervical instability injection with my bone marrow, will that affect my glossopharyngeal nerve with or without? You'll have to tell me what MVD in that context is. COVID patient, I was completely fine pre-MVD surgery, and post-MVD surgery, I'm super active in chronic pain. Sounds like a much, much more complex history that needs to be sussed out as to whether or not you've got cervical instability causing your symptoms, how prior surgeries may impact your possible outcome from that. Normally, prior surgeries have a big impact on your outcome. It's one of the reasons why I tell patients don't do that until you've tried all of this stuff. If this doesn't work, you can always do that, but it's hard to go backwards. That once you start having major surgeries, it impacts stability and all that other stuff. So certainly it sounds like you would need to get in a telemedicine eval, and to do that, contact my assistant, Carla. Denise, my great-grandmother had died from the 19 flu in 1919, affected several generations. Yes, it did. And the funny thing about the 1918 pandemic, if you read about it, is because they didn't have the technology, they made a few changes, right? They shut down some movie theaters. Those were very young anyway. The concept was very young. They shut down a couple public spaces, but they didn't really do too much more than that. Everyone went to work as they were supposed to. Some people wore cloth masks. Most didn't. So if you look at their response to it, it really wasn't much compared to what we've done with COVID. But it was nasty, especially if you were younger. There were a lot of people who died. Andres, just got PRP and some cell injections, Dr. Hansen, and a lot improved, but I feel like my vertebrae still move. My circulation is bad. Is that from vertebrae moving or bad curve? Andres, I don't know your medical history, so I can't comment on any of that at all. So yeah, I'll move on. Sorry, guys, that's my those are my Alaska Malamutes who are there's a ambulance out there. So once they hear an ambulance, they think it's a dog howling. So that's going to last a little bit. Sorry. Andres, do you see PRP and stem cells becoming cheaper down the road? Probably not for this kind of stuff. We've got coverage now. Dr. Hansen isn't on that network, but we've got coverage now from about 800 employers or so, 750, and are adding, lots of Fortune 500 companies every day. So obviously there it's much, much cheaper. It's covered through those insurance policies. But as far as in highly specialized areas like this, I don't see that changing unless you have coverage through your employer. Would love to see affordable price, but you don't have the money to spend. So yeah, so Andres, again, we have about 750 trending towards 800 now employers that we've signed up, and it's all covered through those health insurance plans. Stephen, I've read that you can still enter the USA with an exception from medical facility. Genetics wrote me that it would be possible, and now I'm confused. Yeah, Stephen, I don't know what's possible or not possible. I'm just reading you what's on Google. So from the standpoint of dealing with the U.S. government, you'll have to deal with that. If they tell you that you can get some sort of medical exemption, then we'll have to talk about what that is, what that legitimate medical exemption would be. Jaden, what are your thoughts on peripheral nerve stimulation for occipital neuralgia? I had 2 PICL that were unsuccessful in treating my headache and neck pain. I recently completed a 10-day trial for implantable system, which did reduce my daily pain. I'm currently considering scheduling implantation. Yeah, it's a good question. Let's see, positives and negatives of implantable stimulators. Positives are, I think they've gotten better over time in that we have small systems that don't need to be implanted as the generator, meaning they're just implanting the lead. And I think those types of systems are in general better. The downside of an implantable stimulator has always been that the stuff moves over time. So especially when we had implantable generators with a lead wire that would go up to where the lead is placed, we would see wire breakage happen pretty frequently, or we would see the lead wire move out of where it was placed into another spot. I think some of those issues have been dealt with some of the newer systems that don't have an implantable generator. All they have is a lead that can be stimulated from an external box. Having said that, you still sort of end up with that concept that the lead can migrate. But listen, if there's no other way to treat your headaches, and I don't, know what you had or didn't have, then that's not a bad solution. It's certainly better than a cervical fusion, I can tell you that. Ulysses, what can you actually see the vertebral artery in the ultrasound guidance machine or x-ray? Yeah, ultrasound is not going to be accurate enough for you to avoid the vertebral artery for sure, especially if a patient has any kind of weight behind them. So meaning that your ability to track the needle exactly where it is at depth becomes less with ultrasound, the greater the depth. And in this case, you wouldn't really know that you injected most of the time into the vertebral artery with ultrasound. On x-ray guidance or fluoroscopy, you can use what's called digital subtraction angiography. And so you're guiding the needle, and you put some contrast in, and if you think it could show any kind of vertebral artery uptake, then you run a digital subtraction loop, which then highlights exactly and only where the contrast is going. You can quickly see if it's going with the vertebral artery or not. In the latter case, it's a pretty good system for staying out of the artery. Ultrasound, not so much. I mean, you may see it, you may not see it, simply because of the way ultrasound is. It's very user dependent. So if you happen to tilt the probe just slightly, you're no longer looking at the artery. Or if you tilt it 2 millimeters to the right or 2 millimeters to the left, you're no longer looking at the needle tip. So I wouldn't trust ultrasound as a mechanism to stay out of the vertebral artery ever. The only thing I'd trust would be digital subtraction angiography with contrast. I got a lot of ultrasound machines. We've got a lot of fluoro machines. 2 of them have digital subtraction angiography on them. So we could use either technology. It'd probably be much, much cheaper if I just used ultrasound, but it's not the best technology to do that. Denise, what about MCAS and EDS as cause for CCI? EDS, certainly a cause for CCI, yeah. Bobby, you must be trying to add something here. What was decompressed? You mean the trigeminal nerve was decompressed? If you can tell me there, that would be helpful. Jennifer, I often get a moment of dizziness when I look up, such as when I'm reading something, but then I look up because someone is talking. Okay. And guys, I do have to probably get going. So I'm going to answer the questions that are here just because I've got a 2 o'clock meeting and we're a little bit beyond that. I just looked at the time. Apologize. Without the contrast for an MRI. Yeah, so it's going to be unlikely that we'll be able to diagnose CCI on an MRI without contrast or with contrast. but we would need movement-based imaging, and the most reliable one would be DMX. The chin tuck position method. Gotcha. Yeah, Ulysses, no other clinic outside of Colorado is authorized to do upper cervical injections. We're getting fine hot girls here comments here. Yikes. A study you mentioned about DMX Techna, if I'm not wrong, was based on trauma patients, about EDS patients, normal plus EDS patients. Fact, I would have to say that EDS certainly adds another layer of complication and diagnosis. And what I mean by that is that I've got to prove to myself that if someone has 5 millimeters of overhang on their DMX and they have frank, easy to diagnose hypermobile EDS, is that normal for that person? In which case that person had better have an upper cervical exam or an exam that localizes the upper cervical spine, and they had better have symptoms that match that, or we're not going to treat them. Because I would agree with you, HEDS adds another layer of complication to that calculus. Andres, would have been willing to have access to those employers. Yeah, Andres, it's on the Regenix corporate website. You'd probably A, have to see if your employer is on that list, or B, obviously you can always change employers, but you know, that list is that list. Roger, just tuning in. Advanced review, I can review the recording. Do you have any special protocol with vaccine-induced long COVID? Yeah, I don't recognize vaccine-induced long COVID at all. For about 6 weeks, one day. Yeah, Roger, I don't recognize vaccine-induced long COVID as a thing. And we don't measure temperatures on Oura rings or any of those sorts of things. We're seeing a lot of patient problems related to using these devices that are really, really inaccurate and aren't really accurately measuring temperature like a medical device. Same thing with pulse ox. I can't tell you the number of patients who have come in all freaked out about their temperature, or all freaked out about something else like a pulse ox that was off of one of these devices, only to find that the medical device that has to be looked at every single year and validated that it works every single year didn't match what the device said. Hey guys, there's tons and tons of questions here. I don't think I'll be able to get to them, but I will have Carol, our social media person, pull those off and then use those as comments for Friday, because I think I'll be doing this on Friday. So thanks so much for your time. I do have to get into another meeting right now. I'm 8 minutes late for. I think I got a little bit carried away in answering all these great questions. So thank you so much for your time today. And I will see you on Friday. Thank you.